Welcome back to another episode of PT Meal Physical Therapy Podcast, a buffet of play, therapies, movement, exercise and education, activities and leisure. So, for today's episode, we'll talk about something that is very timely in this state of health crisis that we're experiencing with COVID 19. So, it goes about with different names. So, I'm talking about telehealth, telemedicine. So, more specifically for this topic, for this episode, is telerehabilitation. And to talk more about this topic is one of the pioneers of telerehabilitation in UP-PGH Department of Rehabilitation Medicine, Dr. Carliochico FPARM. So, welcome to the show, Doc Carl.
Hi, Johan. Thanks for inviting me to your show.
Yeah, it's our pleasure. Before we start, I just want to congratulate you in your recent award coming from the Philippine Academy of Rehabilitation Medicine, the Presidential Citation as a top outstanding young physiatrist for your exemplary work in um, where's this excellence in tele rehabilitation.
Uh,
So, how did you feel when you got the award?
uh, Honestly, I felt uh, humbled and also inspired by the award. Actually, telerehabilitation is one of my advocacies, and I started working on telerehab when I was still a resident of rehab medicine back in 2014 to 2016.
Mm-hmm.
And I wouldn't have been able to do it without the help of my mentors
Mm-hmm.
from Rehab Medicine PGH.
Oh, that's nice. Okay, so before we go to our topic, which is telerehabilitation, I usually put the spotlight first on my guests. Could you give us a brief background on how you started in your career and what led you to your current role or position?
Okay. Uh, where do I start? Actually, I am rehabilitation medicine specialist, but
Mm-hmm.
before I became a physiatrist, I was a physical therapist. I graduated from College of Rehabilitation Sciences in UST back in 2007. And then after I got my license as a physical therapist, I worked for 1 year. I did home care. I did volunteering work in AMRC UST.
Mm-hmm.
And I also have other rackets during that
Uh-huh.
term.
Uh-huh.
So I did that for 1 year. And then I decided to go to medicine.
Mm-hmm.
And fate brought me to St. Louis University, Baguio. And God had a plan for me there. Uh, I spent 5 years in Baguio studying medicine, and I met there my mentor who taught
Mm-hmm.
me a lot about research,
Mm-hmm.
uh, Dr. Dumantay, who still happens to be the dean of the School of Medicine in SLU Baguio.
Mm-hmm.
And then afterwards, I always imagined myself actually to become a physiatrist even before.
Mm-hmm.
Uh, After getting my license as a physician, I went to PGH for my training in rehabilitation medicine.
Mm-hmm.
And 3 years after, uh, I was sent to Europe, specifically Italy and Poland, to work on rehabilitation technologies
Oh,
for
wow.
the older adults
Mm-hmm.
or geriatric population. It
Mm-hmm.
was it was through my mentor, Dr. Alvin Mojica,
Mm-hmm.
recommended me as
Mm-hmm.
a scholar of that, or as a recipient of that scholarship grant of NIH, or National
Oh,
Institutes of Health,
uh-huh.
specifically Institute on Aging in
Mm-hmm.
partnership with EU, European Union.
Oh, wow.
And so I spent 6 months in Europe in 2017
Mm-hmm.
and worked on technologies for older adults.
Mm-hmm.
I came back
Oh.
in 2017, late 2017, and
Mm-hmm.
practiced as a physiatrist already.
Mm-hmm.
And now I'm teaching in UP Manila College of Medicine, and I'm part of the attending physicians or attending physiatrists in PGH, and
Mm-hmm.
also in St. Luke's Medical Center and Manila Doctors Hospital.
All right. So, right when you got into medicine, um, you've always wanted to go to physical medicine and rehabilitation. Uh,
Yes.
so, what attracted you to this specialty?
Uh, when I was a physical therapist, or when I was even student pa
Mm-hmm.
of physical therapy, I've always wanted to wear the long white
Code?
doctors use, that doctors use.
Uh,
And, I remember when I was a kid, I always wanted to become a doctor. I like the smell of hospitals.
uh-huh. Really?
Weird in a funny way, but that inspired me to become a doctor, as well as my parents' dream
Mm-hmm.
for me.
Mm-hmm.
Uh, they always wanted to have a doctor in the family. So I'm the
Mm-hmm.
first in our immediate family to be a doctor.
All right. Yeah. So we're going now to our topic, which is telerehabilitation,
Mm.
uh, from the program of UPPGH. So for those who are not familiar with it, ano ba ang telerehabilitation and how did it start in UPPGH?
Okay, so telerehabilitation actually is a technique wherein we conduct rehabilitation medicine consultations and or therapy sessions in electronic means. Okay,
Mhm,
these electronic means may be either synchronous or asynchronous. When we say synchronous, it's real time or live, and in doing so, we use two-way video conferencing, for instance, or even phone call.
mhm,
And for asynchronous means or store and forward technique, we use emails, text messaging, or even file exchange.
mhm,
So using these techniques, synchronous and asynchronous techniques, we are able to deliver rehabilitation medicine services beyond the four walls of our hospital in PGH.
I see. So how did it start? How did the program start in PGH, and when did it exactly start?
I remember when I was a resident,
Mm-hmm,
I did a case report on
mm-hmm,
telerehabilitation, and it was used as a bridge or as a teaching learning tool
mm-hmm,
for medical students in
mm-hmm,
teaching them the principles of rehab medicine. We partnered with a community in Alfonso, Cavite, uh, wherein the rural health unit manned by the municipal health officer there referred their patients to us via electronic means, and we called it telerehabilitation. Actually, it's already uh, been
done
in
before.
different countries, right?
Mm-hmm,
So it's been going on since I think the 90s, if I'm not mistaken, at
mm-hmm,
least abroad.
mm-hmm,
But here in the Philippines, it has not yet been fully adopted, the
mm-hmm,
telerehabilitation
mm-hmm,
technique. Actually, when we talk about telerehab, it's not really a new intervention,
mm-hmm,
but a new way of
mm-hmm,
delivering the usual rehab medicine interventions or services.
mm-hmm,
It's an emerging technology that we have yet to embrace, or that
mm-hmm.
we have yet to do more studies on.
Mm-hmm. Right. So it's just basically the same rehabilitation consult and therapy. It's just that the medium of um, transfer
Yes.
of, like to the receiver is different.
Yeah.
It's like distance, uh, distance learning or distance consult.
Yeah. It's like doing online education or
Uh,
distance learning, right?
yeah.
And especially nowadays, there's online banking,
Mm-hmm.
online shopping,
Yeah.
grocery, even
Right.
online everything.
Right.
So,
Online
online
training, online coaching.
online food.
Mhm.
So it's
So
like that.
So in telerehabilitation, what is the aim of telerehabilitation? Uh,
Okay. Based on our PGH experience,
Mm-hmm.
the aims of telerehabilitation are actually threefold. Okay,
Mm-hmm.
so we do it for service,
Mm-hmm.
we do it for teaching, learning,
Mm-hmm.
and we do it for research.
Mm-hmm.
So for service, we extend our service to our patients who are unable to access rehabilitation medicine service face to face.
Mm-hmm.
We are able to do that by providing tele-support
Mm-hmm.
or tele-monitoring, or providing education to them, okay, and to their families as well, or caregivers. And then second, teaching, learning, we are able to educate our medical students rotating in rehabilitation medicine on the principles of rehab medicine, even
Mm-hmm.
virtually. We're able to reach them. For instance, the medical interns rotating in Alfonso Cavite, we are able to uh, provide support to them,
Mm-hmm.
especially when they encounter patients who are in need of rehabilitation medicine services. Of course, we have to admit that these students are still in need of guidance
Mm-hmm.
from rehabilitation medicine specialists, for instance,
Mm-hmm.
for patients in need of rehab consults,
Uh-huh.
especially the difficult cases, for instance, so that the next time that they encounter similar cases, they'll be able to manage the patients better. And so, in the same way, we provide teaching or educational support to
Mm-hmm.
our principal health officers or general physicians
Mm-hmm.
in the community, remote physicians who might need assistance from a medical specialist,
Mm-hmm.
or in this case, rehab specialists.
Right.
And research.
Uh-huh.
So we talk about research. There's still a lot of areas in the field of telerehabilitation that need research or more studies to back up its effectiveness,
Mm-hmm.
validity, cost effectiveness,
Mm-hmm.
and we're doing that step by step,
Mm-hmm.
baby steps, no, for
Right.
now.
Yeah.
But those are the aims of our telerehab program in
Mm-hmm.
PGA.
So far, the community that you partnered with uh,
Mhm.
is Alfonso Cavite.
Yes.
Are you planning to expand to other communities as well?
Yeah, so that's the aim. But
Mm-hmm.
for now, we are partners with the UP-CHDP, University of the Philippines Community Health and Development Program, because UP-CHDP has a partnership with 5 towns in Cavite called Amiga. That's
Mm-hmm.
Alfonso, Mendez, Indang, uh, General Emilio Aguinaldo, and Alfonso.
Mm-hmm.
Mhm. So these towns are actually part of the UPCHDP program. And one of the towns that we have identified to be supportive or to be interested in doing tele-rehab, and after we did feasibility study in that uh, town, we we started the tele-rehab program with Alfonso first.
Mm-hmm. So can you walk us through to a typical session of a telerehab consult? So what happens in your end and what happens on the other end? Who are the players or the people involved there?
Okay, that's nice. Actually, when we have or when we conduct a tele-rehab session, let's remember there are at least two parties or
Mm-hmm.
two teams, right? Two sides. But there could be more, okay? But
Mm-hmm.
for our purpose, we use or we stick to two teams for now.
Mm-hmm.
One team is in PGH, in the Department of Rehab Medicine. That's called Tele Rehab Team, okay? And the other side, or the other team is the Telecommunity Team in Alfonso Cavite. So in our side, the Telerehab team is composed of the rehabilitation medicine specialist, the consultant, the resident, the different members of the rehab team. So we have representatives from physical therapy section, occupational therapy, speech, and psychology even,
Mhm.
and even the rehabilitation nurses. So we
Mhm.
have a representative from them. And depending on the need of the patient, these representatives are able to contribute to the tele-rehab session.
Mhm.
They're able to give their practical advice or demonstration of specific exercises as the case needs.
Mhm.
Mhm. On the other side,
Mhm.
we have the telecommunity team. Of course, that's where the patient is. And ideally, the patient should be assisted by the primary caregiver or
Mhm.
the family member. And the patient is co-located with the municipal health officer, who is our doctor in the community. Because now what we're doing in telerehab in PGH is the doctor to doctor setup. Okay,
Mhm.
wherein the doctor in PGH is able to provide support from the specialty point of view to the general physician or to the family physician in the community to help them manage their cases better and also to provide service to
Mhm.
the patients there.
Mhm. Do you get the patient's case first before you conduct the tele-rehab session?
Ideally, yes.
Mhm.
So what happens is the municipal health officer in the community texts the telerehab phone in PGH, and in this text there is a brief description of the new referral.
Mhm.
So, but of course, we have to de-identify the
Mhm.
patient. We
Right.
don't use their names, or
Mhm.
we try to respect or keep their privacy.
Right.
Uh, they also text us their chief complaint,
Mhm.
if needed, a
Mhm.
brief history, so that
Mhm.
when we do the tele-rehab session, it will be more concise.
Mhm.
Just the clarifications
Mhm. Mhm.
will be focused on.
I see. So it's always there's always a doctor on the telecommunity side as well. Okay.
That's what we do in PGH. So the
Uh-huh.
doctor setup. Yes.
All right. All right. So the it so it has to be like the doctor from the community has to refer the patient to you for consult. Okay. Got it.
Mm-mm.
So, is it just consultation, or does therapy also happen with the telerehabilitation?
And that's a good question.
Uh-huh.
Actually, what we do in telerehab, we provide both consultations
Mm-hmm.
and therapy services
Mm-hmm.
via virtual supervision of
Okay.
exercises. So
Uh-huh.
the therapists who are present during the telerehab session will provide demonstration of home-based exercises that the
Mm-hmm.
patient and their caregivers can do at home.
Mm-hmm.
So, but when they do that, they should be able to uh, ask for return demonstration from the patient or
Mm-hmm.
caregiver in order to ensure that the exercises are done properly and safely in terms of execution before sending the patient home.
Mm-hmm.
And we also tell them about the precautions
Mm-hmm.
and things to watch out for, and safety measures that have to be observed during the conduct of exercises at home.
Mm-hmm. And do you also do like a follow-up um, session just to see if they're performing their exercises correctly?
Yes, if the
Uh-huh.
patient consents and if the the parties, both parties are available,
Mm-hmm.
much as possible, follow-ups should also be done.
Mm-hmm.
If not face-to-face,
Mm-hmm.
then at least via telerehab. But of course, we always give them options to consult face-to-face with their local health physicians or rehab specialists if needed, or as much as possible.
I see. So
Mhm.
so there's consultation, there's also therapy and follow up. So would there also be a time to like evaluate or assess the patient that is on the other side of the Philippines? So if there are things that you needed to assess from the patient, can you also do that on your
Mhm.
end? Uh-huh.
Yeah, that's a good question because uh, patients or physicians might actually have apprehension
Mm-hmm.
in doing teleconsultations
Mm-hmm.
because naturally we are unable to do hands-on physical assessment when we do teleconsults, right? And
Right.
that's understandable. But given the situation that patients are unable to access rehab medicine services face to face
Mm-hmm.
for a variety of reasons,
Mm-hmm.
and for instance, in this time of the uh, pandemic, where
Mm-hmm.
enhanced community quarantine is being implemented,
Mm-hmm.
there's interruption of rehabilitation medicine services, right?
Right. Mm-hmm.
And so we can just make do with what we are able to come up with, such
Mm-hmm.
as telemedicine. No?
Mm-hmm. Right.
Uh, a subset of telemedicine is telerehabilitation, but
Correct.
I
Mm-hmm.
know other departments are also doing telemedicine already.
Mm-hmm.
Now, in terms of physical examination, what could be done via video conferencing, for instance,
Mm-hmm.
be largely inspection, right?
Right. Mm-hmm.
We are able to inspect or zoom in on the
Uh-huh.
affected body part.
Correct.
We are also able to ask the patient to perform specific range of motion, for instance,
Right.
functional activities depending on the need for assessment. Uh, However, if the patient is co-located or has somebody who is related to healthcare, for
Mm-hmm.
instance, municipal health officer, uh, they are asked to perform the hands-on physical assessment.
Mm-hmm.
If vital signs, of course, vital signs are needed,
Mm-hmm.
and then other parts of the PE that are pertinent to the case
Mm-hmm.
will be done hands-on by the by our local doctor.
Mm-hmm. I see.
Um, we rely on the physical exam of the doctor there who is able
Uh-huh.
to teach and do hands-on assessment on the patient and then
Mm-hmm.
relay to us. Mm.
I see. So aside from the physical assessment aspect of a consult, what other limitations have you encountered with telerehabilitation?
Okay. Uh, well, based on the literature,
Mm-hmm.
there are so many factors that
Mm-hmm.
affect the the practice of telerehabilitation.
Mm-hmm.
But locally, we have limited studies on it.
Mm-hmm.
In my case report, I've cited several reasons,
Mm-hmm.
such as, or several factors, such as first, the lack of research on
Mm-hmm.
telerehabilitation, so lack of
Mm-hmm.
evidence.
Okay.
Second is the lack of acceptance and the
Mm-hmm.
readiness among stakeholders. So the
Mm-hmm.
stakeholders include the patients, the family or caregivers, the healthcare providers, both doctors and the therapists. So that's one. That's the second factor. Third factor is the lack of standard protocols. Okay,
Mm-hmm.
I'm sure there are telerehabilitation guidelines abroad,
Yeah.
but they cannot be applied in our setting. Of course,
Right.
because of many factors such as the technology readiness, the
Mm-hmm.
capability of our internet, for instance, as well. And but uh, nevertheless, we should be able to come up with our own guide or protocol in doing telerehabilitation.
Mm-hmm.
What we have in PGH is just based on our experience. No? So
Mm-hmm.
it works
Right.
for us. So we're just trying to do our best in improving our service delivery
Mm-hmm.
and access to rehab medicine for our patients in the remote areas or
Mm-hmm.
who are unable to access us face to face.
Right.
There are other factors such as ethical concerns,
Mm-hmm.
data privacy concerns,
Mm-hmm.
and of course, admin support is a huge factor. And
Mm-hmm.
we're just so blessed that the administration in PGH,
Mm-hmm.
particularly our department, is very supportive of the telerehabilitation program.
Right. Okay. So far, the mechanism of the Tele Rehab that you have set up is the community refers the patient to you. But
Yes.
are you about to open it like a patient can directly consult your department, like a real telemedicine consult that they don't have to go to a middleman and just access a site or something and go straight to a teleconsult with your doctors?
Okay. Well, in the ideal setting,
Mm-hmm.
uh, there has to be a guideline on
Mm-hmm.
data privacy.
Right,
Okay,
right.
and protecting each side, the stakeholders, the patient
Mm-hmm.
side, and the doctor side. Okay.
Right.
In PGH, what we're doing is just the doctor to doctor setup
Mm-hmm.
in order to respect or in order to abide by those guidelines,
Mm-hmm.
ethical and privacy guidelines. According to National Telehealth Center, which
Mm-hmm.
is housed in UP Manila, uh,
Oh, okay.
yes, because we've partnered with them,
Mm-hmm. Mm-hmm.
especially in the early stages of our program
Mm-hmm.
to now. Um, According to what I understood from National Telehealth Center, they recommend
Mm-hmm.
that the patients being seen by telerehabilitation are those that were previously seen by
Mm-hmm.
the rehabilitation team or by the
Mm-hmm.
rehabilitation specialist and or therapist face to face
Mm-hmm.
before going to tele.
Mm,
Uh,
okay.
so in that sense, you already know the case of the patient because
Right.
you're just following up and
Mm-hmm.
you're just continuing the care for these patients you've already seen face to face.
Mm-hmm.
And in doing so, you already have the doctor to patient relationship
Mm-hmm.
and foremost in
Mm-hmm.
the consults that you did face to face.
Right. Okay. So, because here in the US, I think they've already shifted most of their practices to telehealth, which is even if you're a new patient, you
Mm,
can consult a doctor um, through an app or something that
yes.
complies with our Privacy Security Act, which is HIPAA. So, in that sense, like especially now in the situation that everyone's in their homes and they still need to consult a doctor, so they turn to telehealth, which gives them a direct access to their doctors or
Yes.
to new doctors that they wanted to consult. So is that a future plan of the telerehab?
Yes.
Mm-hmm.
Actually, we have to uh, partner with
Mm-hmm.
the different stakeholders
Right.
of telemedicine in
Mm.
general.
Right.
So in order for us to reevaluate, re-update, and
Mm-hmm.
even further improve the
Mm-hmm.
tele program that we have.
Mm-hmm.
So partnerships with the National Telehealth Center should be continued,
Mm-hmm.
and even information and management system for technical
Mm-hmm.
aspect, even I think with engineers
Right.
who might be able to develop or might be able to help us develop software
Mm-hmm.
programs that are encrypted
Mm-hmm.
and able to um, conduct telerehabilitation using a particular application, for instance, that could be made available to all stakeholders or to all potential clients even.
Mm-hmm.
So there's still a lot to do in telerehabilitation in the Philippines, and I'm very much excited how telerehab could turn out a decade from now.
Correct.
And but this requires a lot of work, a lot of researches, a lot of
Mm-hmm.
trials and errors
Mm-hmm.
along the way. So, but everything begins with the first step.
Right.
So,
Mm-hmm. Yeah, because you've talked about there's also lack of research, and I was just reading a poster coming from a research from a group of speech language pathologists in the Philippines about the feasibility of their telerehabilitation delivery, and it's I think it's just a case study on how they delivered speech language pathology services in a community as well. So they concluded that the ICT, the we call this the bandwidth, the internet connection should be sufficient. The also the stakeholders should be open minded and then empowered, and also the community. There should be policies to be that are implemented that would empower home based therapy and the what do you call this the SLPs as well. So I think it's very exciting to hmm?
I agree with all their findings.
Right. It's a very exciting what the future of telemedicine and telerehabilitation is in the Philippines. If all of our the medical associations can work together
Mm,
and also make a like concrete policy in protecting privacy and data security of the doctors as well as the patients and everyone involved. So it's all yeah, you're right. It's a long way to go. Right.
but
Um,
this should inspire us
right.
to develop telerehabilitation program, and
Mm-hmm.
we should set aside our apprehensions and do
Mm-hmm.
studies
Mm-hmm.
to explore its feasibility,
Mm-hmm.
address the limitations
Mm-hmm.
step by step or one by one.
Correct. So I think probably one of the apprehensions maybe of some would be it may replace the face-to-face interaction of doctors and patients if
Mm,
pure telehealth would be what do you call this would be implemented
mm.
uh, eh, as medical or healthcare workers or providing healthcare services. That's our main thrust. It's the human to human rapport.
Yeah, that's
Yeah.
right. And I agree with you. Actually, papers show that telerehabilitation cannot replace
Mm-hmm.
face-to-face
Mm-hmm.
consultations and or therapy.
Mm-hmm.
I agree with that actually. And
Mm-hmm.
however, what we're providing is
Mm-hmm.
a viable option or
Right.
alternative.
Mm-hmm.
We could offer patients who are in need of
Mm-hmm.
virtual uh, access if
Right.
they're able to do face to face for
Mm-hmm.
whatever reason.
Right. So it's not replacing, but it's um, helping the practice out.
Mm,
Because there's just so much of us in rehabilitation that it sometimes we can't reach areas that are like far from the city
mm,
or where there are no rehab professionals or specialists visiting there. So yeah, you're right.
mm. Especially in the Philippines, manpower is
Mm-hmm.
very limited.
Mm-hmm.
Uh, According to one of our studies, the number of fellows in the Philippine Academy of Rehabilitation Medicine is only around 300, 320. And in the Philippines, PTs are about, I'm not sure, I might be wrong, around 5,000 or even less. OTs, about that number, 1,000, 2,000. And the speech therapists, about 500, if I remember it right. And so we need to multiply ourselves.
Right.
And also our patients coming from the different parts of the country are
Mm-hmm.
unable to access the nearest
Mm-hmm.
rehabilitation facility that
Mm-hmm.
is usually located in the urban areas.
Mm-hmm.
And the distance, the costs of travel,
Mm-hmm.
the costs of the meals, the transportation, the loss of
Mm-hmm.
work for the family to
The,
accompany the patient
mm-hmm. Mm-hmm.
have to be considered, because
Right.
these first hinder our patients from accessing rehab services face to face.
Mm, right. I was just looking again at the poster of the study that I told you about. You're right. The SLPs are around 500 in the whole Philippines, and
Mm.
there are regions in the Philippines that has
Mm.
no SLP, and some
Mm.
regions only have one SLP in the whole
Exactly.
region. Like,
Mhm. And
so
even if, as we know, the rehabilitation facilities are not located everywhere. So
right.
not every city, not every town has a rehab facility or rehab center.
Mm-hmm.
And even if there's a rehabilitation center in a province, for instance, it doesn't mean that they have speech or
Mm-hmm.
OTs.
Mm-hmm.
Common, they have PTs.
Mm-hmm.
But other services and even orthotists,
Mm-hmm.
they might not be available in the rehab facility.
Correct. Right.
We have to establish networking
Mm-hmm.
via tele.
Mm-hmm.
That case.
I see. Right. And also, I was thinking when I saw that you posted your video about telerehabilitation. It's like you're opening the gates to telehealth for those who are what do you call this, entrepreneurial, who are business minded. They can start a an agency or a business that would provide teleconsultation or at least yeah, like that follow up through uh, teleconferencing or telemedicine. So it,
Exactly.
there's a lot of ways to improve on the telemedicine telehealth aspect
Mhm. Uh,
once.
yes, I get what you mean.
Mm-hmm.
But as of now, what we're
Mm-hmm.
doing at PGH is all for free
Mm-hmm.
in terms of providing telehealth services to our community partner. So we do not yet engage
Mm-hmm.
in tele-rehab for profit.
Uh-huh. Uh-huh.
I'm not sure how that will turn out
Mm-hmm.
for pay for healthcare providers
Mm-hmm.
who are thinking of going into this direction, or
Uh-huh.
if already practicing that.
Uh-huh.
But I think each society, the each paramedical society, the PPTA, the PAOT,
Mm-hmm.
even and the medical society, the PARM,
Mm-hmm.
um, probably should have a guideline in
Correct.
place
Mm-hmm. Mm-hmm.
for these for this kind of practice.
Right.
Okay,
Right.
so just to standardize everything,
Mm-hmm.
uh, be proactive in mitigating uh, possible medical legal issues,
Right.
comparison of fees among
Mm-hmm.
specialists,
Right.
how we have to ensure that the care provided by these practitioners uh, that are doing tele-rehab for a
Mm-hmm.
cause are abiding by guidelines, both
Right.
local and international.
Correct.
Uh, you mentioned about Hipaa
Uh-huh.
compliance.
Mm-hmm.
So I think there should be a way to ensure that ethical guidelines are also, uh,
Met.
yeah.
Mhm. Right. Yeah. Yeah. I think that's also one of the like foundations of a good tele rehab, telehealth medicine practice is set the guidelines first, set the policies first, umbrella policies so that each disciplines
Yes.
can tailor their practice to that
Agree.
umbrella guideline. Mhm.
Yes. Mm-mm.
And all of our goals is to do no harm, right?
Yes.
So so it's always for the benefit of the patient or client that we are servicing.
Yes.
Mhm. So we're supposed to protect them.
Yes. That's right.
Mm.
Mm.
Right. So aside from uh, bringing in different communities in the program, and what do you see in long term for the program, the telerehabilitation program in UPPGH?
Okay.
Mhm,
Uh, I think the program for PGH
mhm,
in terms of telerehabilitation
mhm,
should still uh, move forward
mhm,
according to the three arms that we have. So the first arm is service. So hopefully there would be more patients accessing rehabilitation via telerehab if in
mhm.
case they are unable to access face-to-face rehab. Okay.
Right.
Uh, we of course would like to see more patients and be able to serve more communities
Mhm,
and establish partnerships with uh, local communities. And now, in terms of service,
mhm,
okay, we have to reevaluate from time to time our guidelines as
mhm,
well. Okay, and second arm is the teaching learning.
mhm,
So we have to continue educating our young uh, medical students so that eventually when they become physicians they are aware of such program and they're also able to be supported by the telerehab program eventually, no?
mhm,
And then third, uh, we have for research.
mhm,
I'm excited to partner with our healthcare providers
mhm,
if ever they're interested in doing telerehab studies. So
mhm,
I'm more than willing to cooperate with them.
mhm,
Hopefully, be able to contribute to the protocol or to their
mhm.
studies.
Yeah, I'm sure uh, uh, the different disciplines, PTOT, SLP, is very much excited in exploring telerehabilitation as well as an emerging practice for our us rehab professionals and specialists. Um, so
Mm.
yeah, I'm also excited how this would turn out in the future.
Yes,
Hmm.
and thank you very much for inviting me to talk about telerehab on
Hmm.
your show because this is an awareness
Uh-huh.
tool or medium to share my advocacy in
Right.
telerehabilitation.
Yeah. And yeah, I was excited when I saw the video that you posted about the rehabilitation, and it's a good way for people to find out that they can access rehab professionals, even if they're in a place where they don't have direct access to it.
Mm.
So it's there's hope for people from far places to access rehab services. Yeah, it's nice. And thank you again for also saying yes to my invitation. So even though we don't know each other in college, you did say yes.
I remember from UST.
Yeah.
So you were two batches
Hmm.
uh, below, right? So,
Right.
uh,
All right. So I have my last questions. Are we ready for it?
okay.
All right. All right. So in your career, who do you consider as your mentors, your most one of your most influential persons that helped you in your career?
uh, there are a lot actually.
Hmm.
So, am I supposed to say just one?
You can say at least your top three.
Okay.
Okay.
Because in our field, right,
Uh-huh.
uh, we meet
A lot of
mentors,
people. Hmm.
meet a lot of people, meet a lot of teachers,
Hmm.
senior
Hmm.
consultants who are able to teach us, no?
Hmm.
uh, every step of the way.
Right.
But uh, actually, I consider these mentors as angels, no,
Uh-huh. Uh-huh.
by God to help us with whatever we needed during that time.
Mm-hmm.
And we're always grateful to our mentors. So in medicine, when I was a medical student, my mentor was our dean,
Mm-hmm.
Dr. John Anthony Dumantay.
Mm-hmm.
He has taught me a lot about life, actually.
Life,
When I
not
was
just
a
medicine.
care provider, yeah. And he taught me a lot about research.
Mm-hmm.
Whatever I know in research now is or has its roots in my medicine days,
Mm-hmm.
medical school days. And during residency training, our chairman then was Dr. Alvin Mojica,
Mm-hmm.
uh, who was also my mentor, and even up to now. Uh,
Mm-hmm.
and along the way, there are a lot of other consultants and mentors that have taught me and inspired me to become who I am now. And
Mm-hmm.
during that time, of course, uh, we might have not understood
Mm-hmm.
their technique in
Right.
mentoring us,
Uh-huh.
but we were young back then. So,
Mm-hmm.
of course, we now know better, and
Mm-hmm.
we're very grateful that we've met them. We've met each one of them along the way.
Mm-hmm. Right.
Mhm.
So in for the mentors that you've mentioned and the other mentors that you've met in your lifetime, what do you feel are there like traits that you admire most collectively in all of them?
Hmm.
What do they have in common that inspired you and that you felt that they are motivating you and became your mentors?
Actually, what I value most and what I look up to them
Mm-hmm.
is their compassion.
Mm-hmm.
Mhm. I think when you have compassion, the rest follows. So, first and foremost, our compassion should be for others and for ourselves and for our families, right?
Mm-hmm.
Whatever we're doing at home or at work, they're based on our love for what we do, our love for whom we do it for.
Mm-hmm.
So I think compassion is what I admire most in my mentors.
Right. Compassion in what in everything you do for everyone you encounter in your life. That's nice. Mhm. So, second question. I have three. All
Okay.
right. In your own opinion, having been a physical therapist and now a doctor of rehabilitation medicine, what do you think should we do as a collective, as a rehabilitation healthcare professional, specialist, experts, to move forward and further our profession?
Okay. Uh, that's interesting since you mentioned that I'm both a physical therapist, licensed PT, and also a physician.
Mhm.
I think um, what we should value most would be uh, collaboration.
Mhm.
Because when we collaborate, there's mutual respect,
Mhm.
there's understanding,
Right.
there's humility,
Mhm.
and we move forward together, setting aside our differences
Mhm.
and our in the past, right?
Mhm.
So I think if we do collaborate, the different specialties collaborate, the healthcare providers collaborate in in whatever task that has to be done, in terms of service, teaching, learning, or research. I think we could further our society or
Mhm.
our practice.
Mhm. Right. I totally agree because there are a lot of I don't know now, but
Mhm.
before there are some friction between doctors and therapists where collaboration would having collaborate with each other, the one that would win is our end goal is our patient, our the people
Mhm.
that we serve, right?
Mhm.
It's good. Mhm. And So my last question: what are the three ingredients that make up Dr. Carliochico? What are what are those that values, traits, core that you carry with you each day of your life that you think are essential in your career or in your life in general?
Mm, okay, that's the most difficult question. Okay. Uh, First of all, thank you for that question. I think uh, I can't uh, think of three right now, but
Okay.
right. Probably the first that came into my mind is cheerfulness.
Mm-hmm.
Uh, we have to always remain happy no matter the circumstance.
Mm-hmm.
So, of course, it's easier said than done.
Mm-hmm.
There are a lot of difficulties along the way, but I think we have to still put a smile on our face,
Mm-hmm.
uh, thinking or hoping that things will get better.
Mm-hmm.
And second, probably is hmm, probably uh, hmm,
There's no right or wrong answer. This is you. What?
okay, cheerfulness is one.
Uh-huh.
Second is respect, being respectful. No matter what we are able to achieve, or no matter what we are able to accomplish. So we should remember to be respectful to everyone around us, matter no matter how high or how low that person may be in terms of office rank. We
Mm-hmm.
should be able to collaborate with everyone
Mm-hmm.
and respect their dignity and
Mm-hmm.
respect what they're able to contribute to the team.
Mm-hmm.
And we have to be polite. We have to be humble. No, uh, whatever whatever stage in our life.
Mm-hmm.
Stage in our life. Yeah.
Mm-hmm.
And the third is so. Lastly, probably uh, prayerfulness. We have the piety should always be there. Our faith should always be there because based on my experience, I've encountered a lot of challenges during pre-med days. So when I was a PT, I had a hard time coping up with studies.
Really?
Yes, because of so many extracurricular activities. But thankfully, I was able to graduate.
Mm-hmm.
Even I remember that when I was in second year PT, I wanted to quit.
Really?
I wanted to shift to advertising. But thankfully, my mom put some sense into me.
Uh-huh.
Uh, yeah, so I stayed and I tried to stick to my original goal
Mm-hmm.
to become a doctor someday.
Uh-huh.
So I persevered, and of course, with the help of God.
Mm-hmm.
So he had a plan.
Mm-hmm.
And then when I was in medicine, same. I lived for 5 years in Baguio in a
Uh-huh.
totally different place with no
Right.
family or relative. But God sends angels. You know?
Mm-hmm.
So, yeah, just have to be prayerful and trust God. And even up to now, so
Mm-hmm.
uh, He continues to send